Okay, there you go. Everyone, in honor of the Golden Globes last night, we'll have one most handsome Russian. Just kidding.
Is the video on me?
Yeah.
I don't want that.
But it's also.
Okay.
You can turn it off.
I'm just gonna hold my thumb. All right, guys, we're doing the adrenal glands. It's gonna be great. Thanks for that look, Beth. Really. What's the yeah, will be great for my self-confidence. What's the arterial supply to the adrenal gland? There's 3 of them. Well, it's actually kind of cool in that it comes off the inferior phrenic artery, which is not something you necessarily think of. And then the middle adrenal artery comes directly off the aorta, and the inferior adrenal artery comes directly off the renal artery. And that's actually not necessarily intuitive if you look at the adrenal and kidney anatomy. So important to note for when you're doing dissections in these areas. But it's one thing to note is it is very well vascularized, which is relevant for
I didn't get that. Could you try again?
I really don't want this lecture to talk back to me. Now, how about the vascular drainage from the adrenal glands? Yeah. According to this image, yes.
Well, which one is this?
This is the right, but the left side is the same.
Yeah, that's right. The thing that comes off the renal, but.
Yeah, I mean, from what I was able to find, this is correct. Now, there's obviously
I can only do that if something is playing.
there's obviously variations to the anatomy, but this is the most common. And then to your point, for the venous drainage, the left side, which is farther away, comes off of the renal vein versus the right side comes off the IVC for the vascular drainage to the adrenal glands. These are all actually testable things. I've seen these things in test questions, so important to know. And this is all of it together, which is highly confusing, but it shows basically how kind of close everything really is. And an important thing to note here is the anterior to posterior order of these structures. So the renal vein is the most anterior. Then posterior to that is the renal artery, and then posterior to that is the renal pelvis. That is another fairly commonly tested anatomical question.
Okay, I found this on the web for anterior artery that is commonly tested and questioned. Check it out.
I think it's
It's Mickey's phone.
here.
You guys want to
And another, unfortunately, very commonly tested thing, or at least reference thing that's been brought up since maybe pre-medical school, are the layers of the adrenal gland. Does anyone know a good mnemonic or a way to memorize these? Oh, what is it?
Can you go say it into the mic?
Terrible.
So
Hear it. Say one thing. Yeah, wait, no, it's not. Okay, you go say it into the mic. No, it's not loud. Okay, all right, let's hear it. Just tell us yours.
Grandfather Richard smashed his green apples. What?
So that's not the one I use. So yeah, we've got an hour and a half to kill, so please take it away.
Go ahead. Yeah, tell us that more in there. Okay, tell me what is it on before? You have a grandfather. You have a grandfather. Right, everyone find
GFR.
So to repeat that for the group, Dr. Fay's mnemonic has something to do with mashing green apples, where the M stands for mineral corticoids, the G stands for glucocorticoids, And the A stands for androgens. All right. Well, that concludes the lecture. So GFR is the common way to remember this, and then salt, sugar, sex, the deeper you go, the sweeter it gets, is the way people remember what each of those layers do. So for the G, that for the glomerulosa, that produces the mineral corticoids, which produces aldosterone, and then the fasciculata, glucocorticoids, cortisol, reticularis, androgens, DHEA. And then the last one here that we don't necessarily talk about, you just remember it, is the adrenal medulla, which produces your catecholamines. Okay, incidentalloma. How often do we see incidentallomas on CT scans? Wow. Okay. All right, now when you're working these up, so you've seen an incidentalloma on a trauma patient. It's the middle of the night, it's 2 a.m. And you are a great intern or second year. What are you concerned about with these incidentallomas? What are the two things you need to work up in the middle of the night? Absolutely nothing. But the next day, what do we need to work up? Or on an outpatient basis? You need to figure out if it's malignant, is it cancer? Or you need to figure out if it's functional. Both of those things matter. So first, we're going to look at the imaging. What dedicated imaging are you going to get to evaluate a adrenal incidentalloma? A CT adrenal gland, great. Now, what does that mean? Why is that any different than just a normal CT scan? Yes. So that and it's thinner slices, usually 1.5 to 3 millimeter slices. And that becomes relevant in the features we're looking at for potential malignancies on the adrenal glands. So yes, we talked about that. We talked about that. Okay. So what is the size cutoff for concerning features of an adrenal gland? Until 4 centimeters, great. And then how about interval growth? This one, obviously, in a trauma patient is less relevant, but if you're following a patient and you see it grow X amount of centimeters over 6 months, what would make you concerned? Yeah, 0.5 centimeters, great. And then your Hounsfield units, so greater than blank Hounsfield units, fantastic. And then there's certain other characteristics that are harder to ask questions on, but basically if there's internal calcifications, if there's high vascularity, if there's hemorrhage associated with it, that makes you a little more concerned for malignancy. And then to Katie Bug's point about the washout, what is the cutoff for the percent washout at 15 minutes that would make you concerned for a potential malignancy? 30%. So less than 30%. If there's less than 30% washout at 15 minutes, you are at a higher risk for that being a malignant gland or lesion. So now this slide unfortunately got messed up. That's okay. The labs you order for an incidentalloma, you can just remember what labs you order based off of the different layers of the adrenal gland. So if you're evaluating for a functional incidentalloma, you're going to send labs relevant to each of the layers. So for your glomerulosa, what labs are you going to send to evaluate if it's functional in that layer? Yeah, aldosterone, renin, I heard potassium, great. And then for your zona fasciculata, your cortisol labs, basically. There's various cortisol labs. Most often you start with a late night cortisol. The answer for that question has kind of changed over the years, but I think as of right now, you start with late night cortisol. And then the zona reticularis, you send a DHEA sulfate is the recommended lab per BTK. And then for the adrenal medulla, there's a variety of questions. And this is something that probably comes up every year on the ABSITE. What is the first lab you send to evaluate the adrenal medulla? Plasma metanephrines, and the confirmation test is great. And then you can also send VMA and catecholamines as the other serum test you can send. Okay, congenital adrenal hyperplasia, the next commonly tested item on the ABSITE. The best way to really know the congenital adrenal hyperplasia is just to memorize this chart.
You know about this arrow chart?
What? There's an error. Set you. Wow, that was
So that's
satisfying. Yeah, yeah, yeah. Yeah, I mean, warranted. Definitely warranted. So this chart is something I came up with the other day. To remember to remember the associated abnormalities with the congenital adrenal hyperplasia deficiencies. So these are the three enzymes that are deficient in the three different types of congenital adrenal hyperplasia. Has anyone seen this chart before? Raise of hands. Okay, so most of our senior residents. Yeah. It's actually like jokes aside, it's very, very helpful. The BTK podcast obviously covers it, but really the best way to do it is just to sit down with the textbook and just kind of explain it to yourself. I'll briefly go through it here. So these are the three enzymes that are deficient in the three different congenital hyperplasias. Now, what you want to know is you want to know what each congenital adrenal hyperplasia enzyme deficiency does to the body. So to do that, you look at these two columns. And each of these two columns will correlate with one of the digits in the enzymatic deficiency. So this column is going to tell you, this number is going to tell you something about this column. And then this number is going to tell you something about this column. And the way you determine what the numbers tell you is the only thing you have to remember is that 1 means that column is increased. Anything else means nothing, basically. Okay. So to walk through the first one for 21 hydroxylase deficiency. So for our first column, we have 21. So the first column is going to be 2. So 2 means nothing. So for aldosterone, nothing is increased, nothing's changed. For our 1, our testosterone is great. So, and that is what 21 hydroxylase deficiency does. And then, so for the next one, for 17 hydroxylase deficiency, so for our first column, it's a 1. So that means our aldosterone is great. And then for our testosterone, great. And then the last one, they're both increased. So at least 2 of you know that chart really well. Great.
Blood pressure goes up.
Blood pressure goes up.
I was just gonna Frank said his blood pressure goes up before before sex. I just did rote memorization. These are all some good ways to remember it too. Yeah. Okay. All right. So now we're going to go into case presentations to discuss the rest of the etiologies we have to know for the ABSITE. Our first presentation is a 48-year-old male who's on 3 antihypertensives with poorly controlled hypertension, and he has hypokalemia. What is the likely diagnosis? Yes, Conn syndrome, hyperaldosteronism. Great. If you were to send off an evaluation for this pathology, what is the first lab you would send? Yes. And what is the ratio you were looking for on the aldosterone to renin ratio? So there's various things quoted. 25 to 1, I think, is the common multiple choice answer. I think technically 30 to 1 has like the highest sensitivity of like 90% or something, but either way, it's going to be somewhere in that range. And then you send off that test. What is the confirmation test after that aldosterone to renin ratio? Saline suppression test, is that what you said? Yes. So that is where you give 2 to 3 liters of normal saline, and then you measure the plasma aldosterone measurements following that. The other thing you can do is a 24-hour urine aldosterone excretion on a high sodium diet. Don't ask me how to do that. Now, imaging to evaluate for Conn syndrome. We already talked about it before. You use specifically a adrenal protocol, think on CT. Now, what if your CT imaging is equivocal and you don't see, or you're not sure if you see a nodule? Great. Now, how do you know? Does anyone know how to do that? The adrenal vein sampling? Like, how do you know you're in the right place? Like, so basically, you through a variety of mechanisms, you cannulate the adrenal vein, but how do you really know you're in the adrenal vein? It's like a small little ditz. So you look for the place where the cortisol, you measure like an intraoperative cortisol level. And if it's 4 times the systemic amount, you know you're in the right place. You know you're in the adrenal vein. So you look at the serum cortisol level, and then you look at the cortisol level from where you've cannulated the renal vein. Sorry, the adrenal vein. And then once you find that location, you compare the aldosterone cortisol level ratio on each side. If it's greater than 4, it's diagnostic. I don't think that'll ever come up on the test, but it's interesting. Boom. You can also get other scans that are lower yield and don't really help much. So now the management. So around 65% of the time, Conn syndrome is not unilateral, it's actually bilateral. And how do you manage a bilateral idiopathic adrenal hyperplasia? Yeah, you just do medical management. You do your ACE inhibitors, spironolactone, calcium channel blockers, potassium repletion, all that good stuff. Can you cut out one of the adrenal glands to help? I probably wouldn't. Yeah, it's been described. I probably wouldn't. Okay, now if it's localized, let's say you have a one-sided either nodule or adrenal hyperplasia, then what do you do? Great, you cut it out. God, surgery is great. Now, of note, 1/3 of the time when you think it's unilateral, it winds up being bilateral, so oopsie. So people, even when they know for sure, they see on imaging there's a one-sided nodule, they'll cut out that nodule. It turns out it was actually the other side as well. So they still recommend doing venous sampling, or some people do it. I don't know if that's necessarily the right. I think if you have like a nodule and things like that on a test, you could probably just get away with an adrenalectomy. But in real life, people no. Okay. Okay, so do the adrenal venous sampling. I've never had that in a test question. Okay.
Yes.
Yeah, in clinic.
Yes.
Yeah, that's what yes, everything she said. Okay, next case presentation. 43-year-old female. She has autoimmune thyroiditis. She has type 1 diabetes. She's presenting with worsening fatigue, nausea, anorexia, weight loss, and hyperkalemia. Yeah, Addison's disease. Great. Now, what if you had someone who presented with hypotension, fevers, lethargy, pain, nausea, vomiting, similar demographic background? Adrenal crisis, basically. It's severe Addison's, but acute. So Addison's disease, otherwise known as hypocortisolism. There's 2 etiologies of this. One is peripheral, one is central. Can someone tell me what that means? So primary versus secondary. So if it's a primary cortisol deficiency, that means it's because there's something wrong with the, and if it's secondary, that means there's something wrong with the, great. So first test you send for this, actually per PTK is an AM cortisol. I've seen different flow diagrams for this. This is the one that Behind the Knife uses, and that's our Bible, so that's what I'm going with. So you send the AM cortisol, and then if that's low, you do an ACTH stimulation test. And then if the cortisol is still low, you know adrenal insufficiency is present. So you check your cortisol, you know it's low. That's why they have Addison's in the first place. And then you try to stimulate it. And if it's still low, that means something's not working in the adrenal gland. But you still have to figure out whether or not it's just from the adrenal gland, or is it also a secondary? Is it from the pituitary as well? So that's when you check your AM ACTH level. If that's low, then you're more likely to have primary adrenal insufficiency. If your ACTH is slightly decreased from normal, then it's likely a secondary adrenal insufficiency. For your management for these, you give them steroids. in the acute setting, high dose steroids, fluids, etc. All right, what is this? Great. I tried to get AI to generate a picture of a cushingoid patient, and it like wouldn't do it. Oh yeah, for sure. But I wanted to see like what generative AI could come up with, and if whatever reason it like could not compute, no matter how many different ways I asked it. So, anyways, that's a cushingoid patient. They got the buffalo hump. They bruise easily. They got the striae. They have a pedulous abdomen. All the stuff. What's the most common etiology of Cushing syndrome? Wow. What is the first test you send, lab test you send, or one of two lab tests you send to evaluate someone who you're concerned for Cushing's? Yeah, late night cortisol, I think is the most recent recommendation. It used to be 24-hour urine cortisol. It's usually confirmation test. And then what else are you going to evaluate for? Your ACTH levels. It's literally just like our previous discussion. You want to make sure that there's not something from a pituitary source versus just an adrenal source. You send an ACTH level if it's low, it's an adrenal source if it's high. So what if you have a high ACTH level? What two different things could that be? So ACTH comes from the, okay, where else could it come from? Cancer. What kind of cancer? Yeah, typically a small cell is the classic one. And so how do you differentiate between those two? Great. High dose dexamethasone suppression test. Which one will that suppress? Correct. We've already talked about imaging, adrenal CT, pituitary brain MRI, and then for an ectopic, you scan the entire body. Okay, management. So if you have a adrenal producing tumor, you cut out the adrenal. That's great. If you have a pituitary mass, transsphenoidal resection. And if you have an ectopic ACTH producing tumor, yeah, you should treat their cancer. You can resect it if it's possible. It depends where it's ectopic too. And the most common cause is small cell lung cancer. What if? Now we'll go to that later. Okay, next case for a 30-year-old male, poorly controlled hypertension, has palpitations, and they have an impending sense of doom. Some people feel this constantly. Pheochromocytoma, good job, everyone. Okay, what are the rule of tens for pheochromocytoma? So 10% are bilateral and children, yes. 10% are, yeah, and 10% are, great. You guys I didn't know any of this stuff before I made this lecture. So the initial test for a pheochromocytoma, great. And then your confirmation test? Oh, it's your laptop. Sorry, Frank. Imaging, we already talked about this. Now, there's several follow-on imaging that you can do. None of them are really that great. But what is the most common site of extraadrenal pheochromocytomas? Yeah, and then the aortic bifurcation or take up the IMA is where you normally find that. Pre-operative management, they're usually dehydrated, so you got to volume replete them. How do you do the blockade? Great. And what drug do you use? Phenoxybenzamine, which is mucho expensive. You can use prazosin if you want to save money. And then you don't always have the beta blockade, but normally that goes second. But apparently you don't always have to do that. Med-TC. Surgical management is basically you cut out the pheochromocytoma. If it's in the adrenal gland, basically at some point you have to ligate the artery and you have to ligate the vein. Which one do you ligate first? Okay. And that's to avoid a catecholamine crisis from manipulating the tumor. Adrenal carcinoma, this is not a quiz slide. It's extremely rare. It's 2 per million. The presentations, if they are symptomatic, they present with Cushing syndromes, variolation, hypertension, but 50% of these are actually non-functional. They often present very late. They have very poor prognosis. The most of the testing on this has to do with kind of the imaging, or if you have someone that just presents late in life, or like 40 to 50 years old with this like very large gland, just think of this diagnosis. The most important factor for survival is the adequacy of resection. These questions come up from time to time. The 5-year survival with and without resection. So with resection, a 5-year survival is about 50%. And then without resection, the stat I could find on this is the median survival is less than a year. So it's a very bad cancer. Distant or local spread is evident at presentation 65% of the time. So really bad. The management for these is just radical adrenalectomy with debulking. There's various adjuvant treatments for these that you're not going to get tested on. And then since you are, since this is like a highly concerning cancer, you basically do pan-CT every 3 months for 2 years. This is the other kind of thing that comes up. Adrenal myelolipomas, just basically know that it's a large tumor of a benign tumor of the adrenal gland that can be over 10 centimeters. So, normally you would think of an adrenal cortical carcinoma, but in this case, you're going to see like a macroscopic fat instead of more concerning features. So just know that just because it's big doesn't necessarily mean it's a carcinoma. It could be this. Most common etiology of Cushing syndrome, we talked about this. Exogenous steroids, good job. Most common etiology of adrenal insufficiency. Anyone know? So globally, it's tuberculosis. How about in the United States? Autoimmune, great. Screening test for adrenal insufficiency. And cortisol, good job. Intraoperative hypertensive crisis during a pheochromocytoma resection. You give the nitroprusside, we can talk about that, but that's something that comes up from time to time. Most common primary site for adrenal metastasis. Lung. And then additional tests for suspected pheochromocytoma with normal plasma and neurometanephrines, quantity suppression test. There's various questions here that we can go through if you guys want. We're about minutes. Okay. Who wants to take the first one? It's the easiest one.
The 47-year-old man with office for the follow-up visit from syndrome. He feels tired, has headaches, muscle cramps. His vitals are not full for blood pressure, 150 over 90. His labs are significant hyperemia, high aldosterone. So his CT doesn't drop any abnormalities, so you would want to get a adrenal venous sampling.
Yeah. Yeah. Good job. That's to Meg's point earlier. Okay, who's next? Yep. Yeah. Good job. Oh, sorry. That should say C. Yeah, sorry. That should say C. Yeah. My bad. No, yeah, yeah. Okay. So it's actually it's C. It's not, so it's because it's greater, because it's a large mass, 6 centimeters. That and she has no obvious weight loss other than the kind of like B symptoms. It should be a functional adrenal cortical carcinoma. Non-functional, sorry. Who wants to do this one?
22-year-old presents the ED with truncal obesity, round face, fragile skin, depression, and abdominal striae, low dose dexamethasone, spreading test, and 24-hour urine cortisol control, Cushing syndrome. Plasma, adrenal ACTH is depressed. What's the best next step? Right.
So CT scan of the abdomen, yeah. So it's most likely an adrenal source. All right, going on.
52-year-old presents the abdominal pain and breaks down weight loss. She undergoes CT scan with 26 adrenal massive loss, fat plating, and 13-year-old adrenal ABSITE. She does handle locally invasive. She undergoes a full workup and schedules her own block. Adrenal what is the most important predictor of survival? That is the
Yep.
65-year-old man with past medical history of COPD, angina, renal failure, worked up for Cushing's, going to have a 1 centimeter functioning pituitary adenoma. He undergoes transfemoral excision and is seen followed 6 months later with persistent symptoms. His serum cortisol levels remain elevated. His cortisol was elevated. His serum cortisol reduces with high dose dexamethasone. MRI of the ratio of no obvious pituitary mass was the next best step in the management.
This is kind of hard. Yeah. Oh, sorry, it didn't show up, but that is the right answer. And then the last step on this algorithm, if that doesn't work, you can consider a bilateral adrenalectomy, but that's truly like last case scenario. Yeah, yes, basically. Either one, or like reoccurrence even. Next one.
He was underlying history of asthma, mucus, emergency, only for cholecystitis, which is following his most instances of acute anisonic crisis.
Yep. That makes sense. Any questions?
Yes, they have that. So C would be found in B is not right for the potential.
Criticism and the masculinization patient reports her father had some emotions before he passed away.
This one's kind of hard too. No, so it's actually I don't know what happened with the slides. They didn't transfer over, but it's a functional adrenocortical carcinoma. The hint there is that that it's like inherited, and then it's not the congenital adrenal hyperplasia because if you remember our like 21 hydroxylase deficiency, so she actually has like high blood pressure, which you wouldn't necessarily see, and she's older. Yeah.
Like multiple functions.
Yeah, so it's like all the yeah. All right. Go for it.
NBC, his blood pressure is 190 or 85, pulse is 98. His exam are remarkable, showing below. Patient remains persistent hypertensive. CT performed at the time worker was negative for any injuries, but does show an incidental lung. The right adrenal gland was much for rate tests. Nose, so sodium's high, potassium's low.
So it has all the hallmarks of high aldosterone, like you said, high sodium, low potassium. And the way you diagnose that is the ratio of the aldosterone to renin. That's it.
Oh, awesome. And guess what? It's only 10:05 a.m. So.
So we can-
everyone's here.
So we can run it back.
Beth is gonna do her accountability lecture right now. So we can take 5 minutes and then come back in for that lecture.
Thank you. Great job.
I don't think I've signed in academics in 6 months.
I have to stop recording. Did you stop recording already? Okay.
It never really goes to